The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the May 2019 Pre-Hospital Care Research Forum Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Megan Corey, and I'm joined by Dr. Tony Fernandez and David Page. And today we will review the article entitled Survival in Out-of-Hospital Cardiac Arrest After Standard Cardiopulmonary Resuscitation or Chest Compressions Only Before Arrival of Emergency Medical Services. This is a nationwide study during 3 guideline periods, and this was published in Circulation in 2019. Now, this review is paired with an article written by columnist Dr. Tony Fernandez, and this is in EMS World called Journal Watch. We encourage listeners to check out this article at emsworld.com under the category of Education and Training. Also, a reminder about the upcoming call for abstracts. May 31st is the deadline for education abstract submissions to the annual EMS Educator Symposium, and this is at the National Association of EMS Educators annual meeting, July 31st through August 5th in Fort Worth, Texas. A little correction there. You might have read something that says Austin. It is actually Fort Worth, Texas. And also June 30th is the deadline for clinical and systems abstracts for presentation at the 3rd Annual International Scientific EMS Symposium at EMS World Expo, and this is October 14th through 18th in New Orleans. Now there's still time to crunch those numbers and code those narratives and add to the body of research in pre-hospital patient care. So thank you all for joining us today. So let's begin. We want to remind our listeners that you can use the chat feature on your screen to type in questions and comments, and we will bring those into the conversation as we go. Now, we were talking about this just before we began, and bystander-initiated CPR is, we know, a strong predictor of survival in out-of-hospital cardiac arrest, and we know that chest compressions only CPR is easier to teach and to perform, especially by the lay person, and it might be associated with increased CPR rates, meaning performance of CPR, and then it might, then make us extrapolate that maybe there would be an overall increase in survival. That really hasn't been realized. So in 2005, we know there was a shift in the compression to ventilation ratio from 15:2 to 30:2, and the authors point this out in their background. And compressions-only CPR was introduced as an option, and most of this was the emphasis on the dispatcher-assisted, and actually it was followed up in 2010 with the dispatcher-assisted CPR guidelines, giving instructions to bystanders who were maybe not trained in CPR by just instructing them in chest compressions only. And then in 2015, these guidelines recommended that was pretty much unchanged, with an emphasis on the medical dispatcher's role in identifying the cardiac arrest and then providing dispatcher-assisted CPR. Changes in CPR rates and, the impact on 30-day survival, those kinds of things were unclear. So the aim of this study, which is a Swedish study, was twofold. First, they wanted to describe the overall rates of CPR during these periods before the arrival of EMS, and then the changes in the type of CPR in the 3 different guideline periods, the 2005, 2010, and then all the way up to the 2015 guideline changes. And then the second thing would be to assess the important thing, which is the association between the type of CPR and 30-day survival. So I've got Tony here, I've got Dave here. This is an observational study. So we've looked at these registry-based kind of cohort study. What makes this one different, you think, guys?
So I'll start. This is Tony, and thanks everyone for joining today. I think one of the really interesting things about looking at some work from Sweden is that they do a really good job of collecting registry data on all of their citizens. And they have they do a tremendous job on linking data. I think, and we'll get to some of this, but there were only out of an overall out of hospital cardiac arrest population of almost 70,000. There were only about 600 who didn't have a 30-day survival linked to their record. That is fantastic, and it just opens up so many possibilities with what you can do with these data.
So, Dave, and we were talking about this before. Let's talk for a second about just the difference between Sweden and the United States and what we know. They described EMS organizations in 21 regions in Sweden that participate in this reporting of the data, and noting that they use Utstein criteria. So we're talking about, apples to apples, when we talk about, comparing Sweden to maybe the United States and other areas of the world. And then they take this from incident reports. So this is data that comes into some type of a registry, like the CARES registry, I'm assuming, called the Swedish Register for Cardiopulmonary Resuscitation, like Tony was saying. One of the things I noticed in here, Tony, too, is that they not only put sort of the standard data points, but they also note the highest medical educational level of the person performing CPR before EMS arrival. Is that something from CARES too? Do we see this in other registries?
So I'm not sure. I know we get it for providers, but I'd honestly have to go back and check to see if we get that information for bystanders, and I suspect we do not.
Even if we did, I think this is one of the first times that we see it reported, which is sort of an interesting concept, is if the bystander, what's the level of certification or education of the provider or the bystander. So it's kind of nice.
Yeah, I think that's really nice, and I have that written in my margins here. Really, I didn't realize that this was measured, so I think that's an interesting thing. Also, one other thing I want to bring up, and I know it'll probably come up later in looking at the data, but there's this recording the first rhythm, and we know that that's part of the Utstein criteria too. The first recorded rhythm, whether it's a shockable rhythm or non-shockable rhythm, VFib or pulses VTAC versus not, and the one of the things that's pointed out in here is that they reported it, but they didn't report it, or they didn't emphasize it, because they said that the performance of CPR can actually affect that. I thought that was an interesting point, and it kind of made me question some of the research that we've looked at in other areas as well. And did you interpret it the same way I did, that if CPR is performed, this may actually affect the presenting rhythm, the first recorded rhythm, and so therefore you might have more of the survivable rhythm presentations in the CPR performed groups?
Sure.
Yeah.
I think we know that if there is bystander CPR before an AED, we know that circulation is improving, and therefore we know that we could have an improved, a more coarse VFib, or maybe the improvement of a rhythm or the change of a rhythm. So I thought that was that is kind of an interesting aspect of this study. And not to step too far back, but I did look at Table 1 in page 4 is a really helpful table in this particular paper. And in terms of the quantity of bystanders who did have medical education, 2,700 out of nearly 12,000 were medically prepared bystanders. And they did standard CPR. But 900 out of 6,000 were medically prepared and did not do breaths. They just did compression only. So if we're thinking about how lay versus medically trained people respond to increasing the performance of CPR as a bystander, I think that's a fascinating number. Is that our own healthcare people might not want to do mouth to mouth, and maybe I shouldn't be that surprised. Maybe it should have been higher, the number of medically trained people who didn't want to do it. But if you ask me, I've always had this open question about, well, maybe compression only for a little while will or won't matter. And I think when we get to the results of this paper, we know that it does absolutely matter. And that's the big punchline in this particular story, is that standard CPR really actually outperforms compression only. So I'm looking forward to it.
We saw that I think in a study we looked at before. It was one part of the CARES registry. I think Henry Wang and a few others that looking at 30-2 versus continuous compression. So yeah, not too surprising, but let's back up for a second and walk through a little bit more on how they did this, and then bring up that table that you're talking about, because I agree that that's a really good table to bring up, and then we can have Tony help us with some of the statistics here. So these reports that come in, the physician at a regional level reviews them, and then the data on 30-day survival are actually obtained from a population register. So that's where they get the data. And then so this is again a retrospective observational collection, but what they wanted to do was collect the information on these out-of-hospital cardiac arrests and then stratify them into different groups. So I guess what we're seeing right here is how they at least gathered from the registry. So we have the reported out-of-hospital cardiac arrests between these 3 guideline periods, 2000 to 2017, over 68,000 in here. And then we have the exclusion that's pretty standard, non-witnessed, witnessed by EMS, unknown witness status, those are going to be excluded. And then bystander witnessed out-of-hospital cardiac arrest is what the interest group is, so 34,000. And then excluded here, rescue breaths only, missing any kind of survival. That's actually not bad, only 605 missing 30-day survival. Missing information on the type of CPR, and then interestingly enrolled in ongoing randomized trial. So there was a randomized, there were 2 of them, I believe they mentioned, at least 2, on the compressions only CPR and on other aspects of resuscitation. That happened during that time. But again, only 262. And when you think about 34,000 and you're removing 262, not too bad. So ultimately, we get this large group of bystander witnessed out-of-hospital cardiac arrest included in the study, which is a little over 30,000 patients. So we're talking about a large number. And then now we have this table here, table 1, that I think this was the one you were referring to, Dave, that has, it was actually, and this is the one that shows our baseline variables by CPR groups. So we've grouped in, and this is actually grouping the type of CPR that was performed, not the years that we were saying before. They actually looked at the years in a subsequent analysis. But so this is no CPR performed before EMS arrival in the first column. The second column is standard CPR, so that's your 30-2 chest compressions to ventilations, and then compressions only CPR. And then we have, the patients, the number of patients, and age in years, and gender, location, cardiac cause for people that can't see this table. And first rhythm, presenting rhythm of VFib or pulseless VTAC, EMS response time, lay bystander with medical education, and 30-day survival. So Tony, can you walk us through this? This is a pretty, clear-cut, I think, presentation of their data. But what kind of things stand out? And help us with one thing. So when we have students and we're learning research and we see a table like this and we scan across the table, we see a number and then we see the percentage in the parentheses. Now, sometimes the percentage, it's pretty different. So for example, when we see, no CPR performed and it's 40% of the patients, and then we look over in the chest compressions only, 21% or 20.8% in chest compressions only. That's a big difference. But what about when the differences are closer? And how do we know there when they say statistically significant?
So typically you'll want to read through their methods section, and a lot of papers they'll actually define for you what they consider statistically significant. With the overwhelming majority of papers, they're looking for a p-value of 0.05, and if it is less than that, they will consider that statistically significant. That is their cutoff on this paper as well. Or they'll look for differences in your 90% confidence intervals, and to see if those intervals include one between the minimum and the maximum. That also could be an indication that there's of statistical significance or not. What you'd like to see, and statistical significance, one of the reasons I believe why they didn't present a lot of their p-values in this paper is because they had such a large population that they were looking at. And sometimes your population size can drive your statistical significance. Actually, that it's not sometimes. If you have a large enough population, you will see statistical significance just due to chance alone. But the good part about having such a large population is you can, oftentimes you don't need to rely on statistical significance to tell you if it's different or not. With a large enough population, you can actually most of the times let the percentages speak for themselves. So these are, you can't really say what you're looking for in terms of percentages, and how close is close enough to be statistically significant or not. You really want to run those tests and see what your statistical tests bring back in terms of significance or not.
Yeah, I'm glad you said that, because sometimes we see tables that have in the last column will say, a p-value, and then you'll see an asterisk, that says, oh, look at this one's actually significant. And in this case, you have again, like you said, over 30,000 patients that we're including in this. And just scanning through the table, what kind of things jump out at you guys in terms of, differences?
Yeah. So, and I want to address one comment that's coming in from the listeners. So that's great. And please let us know if you want to be unmuted, because there's I look at the list of people who are signed on, and I think that they're really smart, and probably even smarter than all three of us put together can make intelligent comments. But the comment was 30-day survival doesn't seem to be any better between standard CPR and compression-only CPR. And this is exactly what Tony was saying. When we begin to break down the subcategories of these patients, we actually, they write an entire paragraph of how they begin to adjust with, quote, after multiple imputations adjusting for differences in baseline characteristics. So, there's some patients who clearly are in cardiac arrest who probably have way less likelihood to survive, and who are traditionally in that category of, they probably have very little chance. Once you adjust for those types of patients, SCPR, meaning CPR with standard CPR with respirations, does do better than the compression-only CPR. And if I'm going to read their results verbatim in comparison to the SCPR with compression-only CPR, there was no difference overall in 30-day survival. But after adjusting for baseline characteristic factors, it was associated with a significantly higher chance of survival. So odds ratio there 1.2 when you're now adjusting. So I think it's important to take a look at how they look at the populations that they're comparing. So in any study, you sort of think of the types of characteristics once you've gathered all these data, and want to begin to see if there's a significantly different group of people who happen to just receive no CPR versus CPR with breaths or not, or just compression only.
Well, one of the things I think I liked about this study, though, too, and Tony, you can comment because you're the one who actually chose this month's study. So, is not just the breakdown of the different characteristics, but they could have just left it at this and said, let's look at these 17 years. But the real point was to look at 3 guideline groups. So, and to look at 30-day survival and compare the different types. But they also broke it down by, the 2000 to 2005 group, the 2006 to 2010. The 2011 to 2017, knowing that each of these groups, people are going to be following, these are new recommendations that come out. So I thought that was actually the most attractive part about this study and the most novel part about this study was to actually look at those subsets and look at the rates of different types of CPR and then try to determine whether that's that's an element that is affecting survival.
Yeah, I absolutely agree, and that was one of the reasons why I thought this study was so important. Just the fact that when they looked over the different time periods and the different guidelines, they actually saw that they had a 6-fold increase in patients receiving CPR, bystander CPR, and that led to well, the 6-fold increase was on chest compressions only, and it was actually doubled the rate of CPR before EMS arrival. So, and that's the graph right there. Yeah. So I think that we want to get hands on the chest, and we want to get hands on the chest relatively quickly. And I think that this study shows that the changes in guidelines actually help that. And while standard CPR does look like standard CPR should be our go-to for folks who know how to do that or are comfortable doing that, we're seeing good results in terms of survival with compression-only CPR, and we're getting more folks. Well, at least in Sweden, they're getting more folks to participate in bystander CPR, which I think is the goal. So that was really interesting part of this study for me.
Yeah, I completely agree. I want to be careful that we don't draw a causal, cause and effect kind of inference here, that because no compression-only CPR came into be, we suddenly have more people doing CPR, because I don't think the study really measured that. We don't know what other interventions have occurred in Sweden that would increase the number of people doing CPR, and we don't know if perhaps there's some, but it is impressive to have 17 years worth of data that show this gradual decrease. And I think that graph is poignant when it shows you the decrease in patients that are getting no CPR at all, and the gradual steady increase of the patients that are getting compression-only CPR. So, kudos to Sweden and to these research.
I think that's a really great point, Dave, and worth mentioning again. We talk about this sometimes, but this is an observational study, and in observational studies, you can't actually tease out causation. To do something like that, you need a clinical trial of some kind, randomized, double-blind, or the gold standard words that you'd want to put in that. But yeah, and the authors really do a good job, I think, of explaining other things that were going on in this country at the time that could have attributed or contributed to the increase in CPR. There were some social media campaigns, and there were some other randomized trials that were going on in the state. So it's multifactorial for sure, but either way, I think the numbers were trending in the right direction.
And the other thing was the dispatcher assisted. I think they raised that issue too. I believe there was a study going on about increasing the dispatcher assisted performance of CPR, which is usually compressions only. I think though and this is a beautiful graph that shows that change over time, but one of the interesting pieces is the last 3 years in it, when we see standard CPR and being, well, and I don't know if it's being replaced by or surpassed by, or if it just, again, we can't really tell all of the details, but we see the rise certainly of compressions-only CPR and the reduction in the other two. So, which, again, raises a lot of questions in my mind. One is, is this the rise of dispatcher assisted? Is this, what is this? And it's a little bit concerning, I think. Only maybe just because I'm an educator and with students all the time, and before we came on to the podcast, we were talking about this. I encounter a lot of students from different counties who come into the prerequisite courses and the paramedic courses, and they commonly use this, very proudly talk about their system using a high performance CPR in their system and how it's making a difference. And very few have data to back up, but it seems to be sort of a cultish kind of following. And a lot of times when they use this term, quote, high performance, what they're talking about is compressions, continuous compressions. Now that may not be compressions only, they're talking about continuous compressions, but we've talked about this before, and we've looked at a lot of studies before, and we're talking about, are there earth-shattering data that show that one is superior to the other, and we really haven't seen it. And yet I think there is an impression out there that there is a distinct difference. And I don't know, is this passing? What is this trend at the end here, and are we going to see that around here, and what kind of impact will that have on survival? I don't know, but
those are great comments. We know now, compression fraction, pauses, all sorts of other elements of doing these compressions are part of high performance CPR. So I loved one of our listeners here, Luis, is making great comments about, if there's a bystander present, maybe they're doing better CPR. I don't actually know that, but I think it's good to infer that perhaps they might be more aware of better CPR. And I think that there are new philosophies and tools that are emerging to measure, the depth and the pause when there's people who are trained to do it. But those tools are not generally available to a bystander necessarily. And as we, deploy new technology, new AEDs, maybe we'll get better about understanding or at least measuring those things without having to interpret each tracing. So if you're thinking about doing research, because I know we have some people who have access to a lot of information on this podcast, and I'm again going to encourage them to speak up. There's a concept about having to analyze and code every one of these cardiac arrests and be able to begin to tease out some of those key differentiators that make for better survival. And that, the high performance, I don't think we can say that's just compression only, but it's really interesting to know that compression only does improve survival. So if that's the only thing you can do, go at it, because it does seem like more and more people are performing it, while the rate of people who are doing standard CPR has been fairly similar, if not dropped.
Yeah. You're talking about a variety of things that may affect the outcomes of patients. And one of the things we were talking about before coming on here is looking at the data itself, and how we evaluate the data can affect that as well. And one of the things they use this term in here, they account for missing data. So they say 18.4% missing data, multiple imputations. And you used that word, Dave, before. And we've got Tony on, so I've got to ask him, can you help me with this missing data? And does that, we're talking about right now we were just talking about other variables that are clinical, things that might impact the outcomes. But what about the evaluation of missing data itself? How does that affect what we're looking at?
Yeah, absolutely. So let's talk a little bit about kind of how missing data can skew your results. kind of before we move into what imputation is. And the problem with missing data is a lot of times you know it can skew your results, you know it can introduce bias, but you're not exactly, it's hard to understand in which direction it's skewing your results. And you're going to get missing data. This is just a fact of working with registry data or any type of data collection method that particularly retrospective. You're gonna have missing data, and you're gonna have to figure out a way to deal with it. A lot of times, missing data can lead to not being able to detect a difference when one is there. Missing data can lead to kind of a reduction in precision and a reduction in the power of your study. So again, that's being able to detect the difference when one is present. So there historically have been a whole bunch of ways that you can deal with missing data. None of them is, I would say, great because data is missing, and ideally you'd want 100% of data, and that would be great. But imputation multiple imputation is what is valid and statistically valid. And what you do essentially is you're looking at other variables that were collected, and within all these other variables that were collected, you develop multiple data sets, and you impute or you put an answer in or a selection into the box that's missing, and based on what other elements are there. So you do this for multiple data sets. That's why they call it multiple imputation. And then you run models on every one of those data sets that you've created with the data that were inserted into the missing variables. You run those models for every variable, and then you run a separate analysis to combine your estimates from all of those variables. So we talk a lot on this podcast about how there's a lot of research that anyone listening can do. Multiple imputation is one of these things that you really want to handle with care and get someone who's an expert in this type of data manipulation to work with, because as you can imagine, if you veer off kind of from standard practice, you can really skew your results. And there are some analyses that have been kind of widely published and widely talked about in the missing data, I guess, subgroups. And there was one study particularly that used multiple imputation and found that there was no association between cholesterol levels and heart disease. However, when they used just the complete data set, that the relationship was what we would expect. Those authors went back and redid it with a little more care taken to the multiple imputation, and they did come back and say that the relationship was what we would expect with cholesterol and heart disease. So multiple imputation is a way to handle missing data, to put values into where data were missing, so that you can run some robust analyses. And it is statistically valid. That's been proven multiple times, but it should certainly be handled with care and done by a professional.
Thank you for that.
I'll pick up where you left. Sorry.
No, go ahead.
So I'm going to pick up where you left off, because when you start looking at what their imputations are, I think listeners might not have access to this table. So on page 7, they go through and start listing the subgroup analysis: male, female, age, location, home or outside the home, and cardiac, non-cardiac etiology. What's interesting to me here is when we get to response times, right? So if we would assume that the shorter the response time, because we spend a lot of money, at least in the U.S., trying to get ambulances and other resources there as fast as possible, it's pretty much what you would expect, kind of. So response time between 0 and 4 minutes. do pretty well, and standard CPR outperformed the compression-only CPR in these 0 to 4 minutes, 5 to 9 minute marks, but it really outperforms the standard CPR outperforms when response times are 10 to 14 minutes. And then you begin to see a generalized drop off of everyone dies, 15 to 19 minutes and greater than 20 minutes. So a response time of greater than 20 minutes is really negatively associated with survival, and it's kind of what you would expect. What I was wondering, Tony, is as you try to interpret this in the compression-only CPR, you would assume that that only goes along so far. Like after a while, you're going to have to put some oxygen in there, of some sort. And I think what this is showing us is that's in fact probably true. The performance of or the survival rate from compression-only CPR, if we only look at that, is peaked at a response time of 5 to 9 minutes. In general, I'm sorry, 5 to 9 minutes, and much worse when it's longer periods of time, 10 to 14, 15 to 19, and 20. But interestingly, I would have thought it would have done much better 0 to 4 minutes, and it's kind of hovering near each other.
Yeah, I mean, I think
I got you silent, which probably means that you're like, where are you going with this, Dave?
Yeah, I'm sorry. This is a great table, but I couldn't fit it in the slides. A great figure.
It is kind of long for it's very long for a slide, but yeah, I think that the take home there is that compression-only CPR is a good option, particularly when response times are short. I think that to your point, the longer someone is down and the longer before we can get a professional rescuer there, chest compression only CPR certainly does start to get outperformed by standard CPR, and I think physiologically we can probably understand why not having any oxygen circulating for 10 to 14 minutes is an issue. But I think one of the things, and I think this started with a question about how imputation might impact that. I think one of the things that's really important about multiple imputation is that you have to be pretty certain that your data are missing at random. That there's no push one way or the other for missing data. So, in other words, all folks of all races and ethnicities and genders, their data are missing at equal percentages. In other words, or again, the missingness is random. And one of the ways you test for that and kind of validate your results is to run the same analysis without imputation. And when they did that in this study, their results were very similar, which is comforting to folks who were not so comfortable with the idea of imputing data into missingness.
Yeah, I'm really glad you put that. You made that statement, because that was one of the first things I thought is what population is getting this long response time. I mean, how, and what's the difference between the population of people that are out at the greater than 20 minutes or even 14 minutes, according to this. Once we get to 14 minutes, we're seeing that maybe compressions only loses its value. So that's the first thing I thought of, is what's the difference in the population that's receiving a later response time in terms of their health, anything that will affect their health outcomes.
Well, and one would assume these are either difficult to reach patients in an urban environment that vertical response times, but likely also just rural response times, in which case it's just there's less care, less arrival of bystanders, etc. So it does make sense that those numbers are higher, and it makes sense that I'm surprised actually that there's that many people that are in a short response time zone, 8,000 of them that didn't receive CPR.
Yes.
So you're like, that's urban environments where you would expect someone, if we were targeting education, but who knows?
I've got to bring up this one. This is figure 3, and this raised so many questions in my mind, and the authors brought this up too. This is the figure 3 on page 6 has the guideline period and data points for survival in each of the categories: no CPR, compressions-only CPR, and standard CPR. And the first thing I thought of was, wow, look, the survival rate in the no CPR group is rising. So, what are those factors?
We're getting better. I think EMS is getting better at resuscitation.
Well, and this is no CPR before we get there, right? So this is it. Yeah. So it made me start to think too. So these are the out of hospital cardiac arrests. Now, what about on the way, pre-prevention end? If suddenly care for the prevention of heart failure and hypertension and type 2 diabetes and type 1 diabetes and all the things that we know that impact cardiac arrest. If suddenly we were to see a shift there, then we are going to see a shift in the types of patients that enter into this study to begin with, right? The ones that actually end up in cardiac arrest. And, are we going to be left with sort of the sicker patients and therefore maybe not see as much of a bump in survival, regardless of what we do? So that's the other thing I think about is, all of these way upstream things are going to affect what we do downstream and what we measure. So it's like we have to pay attention to all of that, all the chronic care of patients with atrial fib and hypertension and diabetes and smoking and all of the things that we know that affect
you are such
cardiovascular health.
I see the world smoking more, drinking more, dying more aging more. There's going to be more, I would love healthcare to improve and people to improve their health, but it's kind of job security, I guess. I don't know. Maybe I'm being too callous.
No, that is to your point, Megan. That's one of the reasons why most of the time when you're reading research, they will call their results estimates, and that is because every investigator understands, or they should understand, that there are unmeasured variables that are important in any analysis. You're not going to get you're not always going to be able to get things like prevention and lifestyle into your analysis. So you're always doing the best you can with the elements that you throw into your model, and understand that you're always going to not be accounting for something.
Yeah, and I think they did a really good job here of talking about the limitations of the study. As a matter of fact, they went through, strengths and limitations. So they outlined these in several, in a paragraph, several paragraphs in the end here. I have to say, I'm not sure where to take this in terms of, I'm still having a hard time when we do ACLS with our paramedic students, when we want to run simulation. So it's simulation-based education now. And, you have students coming from, again, different counties, different areas, and they all want to apply their own protocols, and we need to standardize it, and we usually standardize it to ACLS. But I'm finding this now and trying to translate that into what's happening in research. Are you finding that at all, Dave, in your education?
Yeah, I think so. And by the way, for our technical people, I think Dr. Myers is on the line, and he's raised his hand, so maybe we can unmute him for a comment. But I think that this study gives me hope, frankly. When I think about just how hard we've worked over the last 17 years in this particular set. 17 years of trying to get people to do CPR, it does mean that more people are surviving. And I think the message to paramedic students is, with any kind of compressions is better than no compressions. So let's try and at least get people either by dispatcher assisted CPR or helping them, training them, and that survival does depend a little bit on how quickly we get there. So we have to think of smarter ways to get to our patients or get people who know what to do there quicker.
I think it would be good to have like kind of a must-read list of a few of these studies for paramedic students, just to be critical thinkers about how we look at cardiac arrest and survival. If you remember, we were looking at that, I think it was a Canadian study. Was it the one where we looked at quality of CPR by bystanders? And I thought that was an incredible study, and I remember they were able to actually measure the quality of the chest compressions and show that as the quality of chest compressions improved, the survival rate improved. And I thought that was that's something that I know someone mentioned earlier in a comment. So that's something I thought that was an important one, and I thought this is a really good one for students to read.
Yeah, I agree.
I think we have Dr. Myers, do we?
Yeah.
Yes.
Yeah, thanks for letting me weigh in. Can you hear me okay?
Yeah.
Great.
Okay, great. Well, thanks so much. This is a fascinating discussion, and just a couple of reflections on here from the practical component in the question I think that was just asked. What do we now tell our students with this paper along with everything else that we know? And I just encourage everyone to go back to look at Gilmore, Ray, Becker, and Eisenberg's work around the three-phase model of cardiac arrest, where they actually measured, there's an electrical phase, there's a circulatory phase, there's a metabolic phase. And the interesting part here is that what we're seeing in this observational study matches clinically what we would anticipate, which is, quite frankly, if you do anything in the first 4 minutes, you're probably in pretty good shape. Once you get beyond that, we really need to keep shockable rhythms course, which is a compression generated activity. And once we get beyond that block, then we have to reintroduce oxygen because we have inevitably run through the supply that was on board at the time of a witnessed sudden cardiac arrest. So there's a really nice logic here that matches physiology. So I don't want us to get too far down the road before we really reflect on that time table that we looked at earlier. I just think that's so important. And then the other piece, which I just can't echo enough, Dave, is this notion that all ships are rising. And even when you receive no compressions, we have improved our resuscitation technique that everybody is doing better. And that's one of those things we really want to try to trace down and see why it happened. But to your point, we should not neglect to reflect on the joy that it has happened. So thanks for letting me comment. I just want to put those two things out there.
Cool comment.
Very cool comment, and I love the extrapolation to physiology. Just like we talk about how we really can't do that, but we really it's nice when it actually matches what we've seen in the past.
Well, I no longer am giving 2 amps of bicarb and putting in an EOA before I start compression. So I think that's better.
So where do you think we go next with this then? I mean, what would you do if you were the?
I hope people are still gonna, participate in these registries. I would love this particular methodology repeated with U.S. Information and see if, in fact, what they found in Sweden is also occurring here. It's just a little bit nicer and cleaner when you've got a national group that has been, tracking the same information religiously. I think CARES has risen and now tracks and has way more participating institutions. So I think that's the number one message: is look at the power of being able to do this longitudinally, and let's be more conscious about how we deliberately change our practice so that we measure it and see if those changes actually matter. Otherwise, I think, we have been honestly trying to find that one thing in resuscitation that is going to change the whole game. I remember back to, is it going to be amiodarone, or is it going to be, megadose epi, or so. I think now we see this as such a multifactorial kind of illness, and the factors around resuscitation are multifactorial. I can't wait for what happens when we get drones out there who can give you two-way video communication and an AED, and perhaps I don't know. I love these new bracelets that tell us how quick and how deep we're compressing. Some of that is educational, but some of it is definitely operational. So it should be interesting to see over time what we can do with just-in-time education, not just pre CPR certified individuals. So
I think it's great that they point out that any type of CPR was associated with survival rates that are 2 to 3 times higher, regardless of which time period, and as long as something was done like we've talked about in the past. And certainly maybe the quality of it has gone up, and the availability of AEDs, the comfort level with bystanders, the dispatcher training, all of these things may affect it. But it's not just healthcare provider education as well. It's the layperson level campaigns of getting out there and making sure. It makes me wonder about the 40% of no CPR. And just the reasoning behind it. Was it, because this was a terminal patient? Are these, what are the characteristics of the no CPR group? And are there missing, how many of those are truly missing something where maybe CPR, it was a missed opportunity? Tony, did you have any thoughts about this? Any thoughts about, like, if you were to continue this, maybe in North Carolina, if there's something like this going on, what would be your next step from this information, your next research step?
So, I think that we've talked about a lot of them. Particularly, all the comment about all ships rising. Can we identify kind of what's leading to that, particularly in the no CPR group, and teasing out a little bit more of the difference between compression only and standard CPR. That would certainly be, I think, an area that's ripe for additional research. But I agree with Dave's earlier comment that it would be great to see something like this replicated in the United States. It would be interesting. We talk about this all the time, and I get really excited when I see a lot of data, particularly with a lot of outcome data. And it'd be interesting to see if we could find somewhere in the states that have such a high linkage percent or outcome data linked to their EMS record or their records, because to have just 605 cases that didn't have 30-day survival, that really is impressive, and I'd love to see something like that in the States.
Yeah, I echo that. I love Tim's comment here. Smart comment about it'd be interesting to be able to figure out if it's in fact if the bystander involvement is an education issue or an emotional issue.
Yes.
So, compression-only CPR comes from, I think, in part, a concept that it's easier and that there's less fear because of perhaps either, you're going to pick up a disease, or it's more difficult because there's more steps. And if you could just do one, what would you do? But there's also this constant concept of, am I going to really help somebody, and if what's the how can we make bystanders be less afraid to help them? And there's a whole multifactorial piece to that. I was just talking to people who train dispatchers in Mexico, and they've focused a lot on tone of voice and how to make them more to help the person calling be feeling more listened to and empowered. And I thought, it at first sounded very touchy-feely to me, like, well, we just need you to actually do compressions. But it's that initial, how do you establish trust between two people so that the other person will do what you ask them to do? And I find that fascinating to think of how we perhaps are driven by numbers and speed, and we're forgetting that human aspect of all this.
Yeah, all great points. And the authors themselves point out when it comes to next steps, randomized controlled trials, and that's what we've been talking about, needed to answer the question of whether or not CPR with compressions and ventilations is superior to compressions-only CPR in cases where bystanders have had previous CPR training. So these look like great, laudable next steps for any system. Any final thoughts as we close out the podcast?
I just want to encourage our listeners to send us ideas of topics they want to cover. We always want more involvement and more unmuted involvement. So if you're wanting to come on the journal club, a journal club is by definition a group of people. So please consider this an open invitation. And again, I just see the list of talented individuals who are listening, playing voyeur, and I think, oh, I know you've got some thoughts in there. So don't be shy, but also help us identify the research that's really making you think.
Great. Thank you all, and thanks for joining us today. We'd also like to remind everyone that the Education Research Podcast will be held on the fourth Fridays of every month, and you can join us for our Education Research Podcast later this month on Friday, May 24th at 10 a.m. Pacific, noon Central, when we discuss influence of patient race on administration of analgesia by student paramedics. This is by Bill Lord and Sahej Khalsa. This research came out of the Fisdap Research Summit and was highlighted at the National Association of EMS Educators annual meeting. So it should be a great discussion. So join us, and we will be back here with our clinical podcast on the second Monday of the month, June 10th. So join us next time. If you want to present an upcoming article, email David Page at dpage@emsed.net. That's dpage@emsed.net. See you next time.